Hello, am I audible?
Yes, you are audible.
Hello, everyone. On behalf of World NCD Federation, I would like to welcome all the participants and the distinguished faculty and the speakers for today in this very important webinar in our international webinar series on COVID-19 and NCDs. For today, which is the Regional Public Health Dialogue for COVID-19 Pandemic Response in Latin America, the critical appraisal lessons and the challenges ahead. Today, the moderator of the webinar is Professor J.S. Thakur, the President of World NCD Federation, and I would like to welcome him for his opening remarks and also for the introduction. Professor J.S. Thakur, he's the professor in Department of Community Medicine and School of Public Health, PGIMER, Chandigarh, India, and is also the president of the World NCD Federation since 2015, its inception. He is the expert member of the Mission Steering Group of the National Health Mission, which is the highest policy-making body of Ministry of Health and Family Welfare of the Government of India. He is the chair of the first World NCD Congress, which was held in Chandigarh in 2017, and also the co-chair for the second World NCD Congress to be hosted by University of Michigan in USA 2022. He's the collaborator for Global Burden of Disease Study by University of Washington, the Pure Study by McMaster University, Canada, Million Death Study, University of Toronto, and Aja in India. He's also among the top 2% of scientists globally, published by PLOS Biology in 2020. He's provided consultancy at international level to many developing countries, including Maldives, Sri Lanka, and Timor-Leste, and many Indian states. He's also the director for 3 centers of excellence of World NCD Federation, which includes the evidence-based research in NCDs and LMICs, the Center for Implementation Sciences and Research, and also the Center for Sustainable Development, Health and Wellness. For COVID-19, he's led the fight against it at the global and national level as a frontline warrior and has initiated this international webinar series on COVID-19 and NCDs. He's also the member of Indian expert group on COVID-19 constituted by Ministry of Health and Family Welfare, Government of India. I welcome Professor J.S. Thakur, and I'll hand over this webinar for the moderation.
So thank you very much, Ria, and good evening and to all of you from India, and good morning to all the people from the Latin American region and the North America. It is indeed a pleasure for me to moderate this panel discussion, and this is a very eminent panel of experts who will be speaking in this session. Just to give you a brief introduction about the World NCD Federation. World NCD Federation is a professional association working for global NCD agenda with a focus on public health approaches to non-communicable diseases. And our focus is strengthening of primary and secondary healthcare systems for addressing the non-communicable diseases. So it was, conceived in 2015, and for the last 6 years, we have now branches in Southeast Asia, Africa, Latin America, European region, Western Pacific region, and Southeast Asia, as well as the Caribbean islands. We have many publications, which include a book on public health approaches to non-communicable diseases, and also the 3 health promotion manuals in 3 different languages. We also publish International Journal of Non-Communicable Diseases, which is the official publication of World NCD Federation, and is published quarterly. And we have also, recently come up with 3 Center of Excellence. One is evidence-based research in low and middle income countries in NCDs, where we commission systematic reviews and meta-analysis. Right now, there are 30 systematic review meta-analysis which are being conducted in the different areas of NCDs. And we have also now a call for Latin American region and Africa region specifically. We have also a second Center of Excellence on Center for Implementation Sciences and Research, where focus is on implementation sciences and research. And right now, 5 or 6 projects, including one in Africa, is working. And the third center is Center of Sustainable Development, Health and Wellness. And the focus is here to address the sustainable development goals. So with this brief introduction about the World NCD Federation, we have started this international webinar series on COVID-19 and NCDs. And we are aware that this comorbidity due to COVID-19 and non-communicable diseases is a very important public health problem. And most of the people dying due to COVID, they are usually having comorbidity due to NCDs. So to keep this issue in focus, we have organized this World International Webinar Series, and this is the 11th webinar which is being organized and is specially dedicated to the Latin American region. And we have conducted the seminars in the past in the Africa region and in other regions. So with this brief introduction about the World NCD Federation and this webinar series, now it is my pleasure to invite the first speaker of the panel, and he's Dr. Victor Jamura. He's professor at Cayetano Heredia University, and he's also the past Minister of Health of Peru. Dr. Jamura is a medical doctor with a master's degree in public health management, planning and policy, and postgraduate studies in health economics. He has 25 years of experience in health systems and services, 10 of them working internationally in more than 10 countries in Latin America and the Caribbean. And he has a extensive experience working for DFID, UNFPA, and PAHO, WHO as health policy and health system advisor. Currently, he is working as a CEO of the Governa Consulting Firm. So it is indeed a pleasure to have him as the first speaker for this session. And his topic is COVID-19 pandemic and comorbidity due to NCDs in Latin America, experience and challenges in different countries in Latin America. Over to you, Dr. Jamura.
Very good morning. Thank you very much for inviting me to this meeting. I don't know if you are listening to me. Is the audio okay?
Yes, you are audible.
Okay, thank you very much. I have gathered some information for this meeting that I want to share with you. I will share my presentation. Please let me know if you are seeing that.
Yes, it is visible.
Okay, thank you. Well, good morning again. Let me thank the organizers for inviting me and being part of this magnificent event with such distinguished professionals. This is an extraordinary opportunity, not only to address the global audience, but most importantly, to learn from you. I would like to congratulate to the organizers for this effort. The task that has been set for us is by no means simple. As a former health minister and responsible for leading a country's health efforts to fight the pandemic, I have been asked to extract some reflections and apply them to the challenge posed by non-communicable diseases. This is a highly complex task in the Peruvian case. The most relevant problems of the Latin American political, social, economic, and cultural reality and the challenges of its health systems are concentrated. It should not be forgotten that this region and my country came to be considered the global epicenter of the pandemic due to its high rates of mortality by COVID-19. At one point in the pandemic, 10 of the 15 countries with the highest mortality were from South America. Today, the situation has changed. But although Peru leads the table with the highest mortality per million inhabitants, 8 other countries in the region are still part of the 30 countries with the highest global mortality rates. In this session, I will address 3 topics. The first is to review the main roles of the health system. Secondly, the fractures that limit its results. And finally, the main challenges we face for the future in the Latin American context, for sure. So it is relevant to ask what are the main responsibilities of a health system. As you know, the 3 main objectives of having a health system are to improve health, financially protect those who fall ill, and finally, that those who use the system are satisfied with the services. As I have already mentioned, the countries of Latin America and the Caribbean have not performed well in the pandemic, but this reflects similar performances in other areas where our indicators, although we have made some progress, continue underperforming when compared to more developed countries. This is our performance in terms of COVID, but this was the same in terms of maternal mortality, where most of the Latin American countries are below what we expect to have compared to rich countries. This is neonatal mortality, the same figures in terms of being behind of those who are more developed. And the same can be said about cancer, obesity, hypertension, and diabetes. The same can be said regarding the satisfaction of users of our services provided by Latin American health systems. As can be seen in this study carried out by McKinko and others in a sample of 6 countries in the region, that the satisfaction levels are very high, especially in the first level of care, precisely where we recommend care to be given, especially for non-communicable diseases. The Latin American countries also show serious limitations to protect their citizens from the financial risks imposed by the disease, especially that derived from the expenses destined to medicines, as was seen during the pandemic, especially with the expenditures that families had to make to access essential medicines like oxygen. Out-of-pocket spending in Latin America is considered, on average, one of the highest in the world. The same can be said about catastrophic spending. As a result, millions of people are dragged into poverty just because they get sick. Although the factors are multiple, I present to you what I consider 4 of the most important. 1, weak governance. 2nd, the precariousness of our health system and the inequity of its distribution. 3rd, fragmentation and segmentation. And 4th, corruption. Of course, all these factors were already present in our system before the pandemic hit us. The pandemic revealed it in all its rawness. I will start with the first factor, weak governance, which has been considered by Francis Fukuyama as one of the key factors that differentiate countries between those with good or bad performance in the face of the pandemic. States with good governance, measured by the good capacity of the state to provide quality services, high level of trust with the government and among citizens, and good leadership, have been able to better implement their containment and mitigation measures. On the other hand, countries with weak state capacity to provide the quality services that citizens deserve, with the trust between governments and their citizens, as well among the citizens themselves pulverized, have had a very poor performance. Lack of trust is expressed in high levels of polarization and social violence, and with leadership, both from parties and people, practically non-existent or very weak, have had a poor performance. In recent years, in most Latin American countries, we have observed large citizen mobilizations and permanent government crises. In the case of Peru, this has led to the fact that during the 5 years, my country has had to be elected twice for the formation of Congress. We had 5 presidents of the Republic, 4 of them in the middle of the pandemic, and 12 ministers of health. The weak capacity to provide essential services is part of the drama in Latin America, the most unequal region in the planet, and Peru is no exception. These inequalities are expressed not only in the high levels of poverty, but also in the poor living condition and the poor coverage and quality of public services, which have determined very high levels of contagion in our population. Living in overcrowded conditions, the majority with manual and informal employment, without means for remote communication or food storage and access to water or basic sanitation and bank accounts for emergency financial transfer, acted as major barriers for implemented control measures, like especially non-pharmacological ones, distancing, hand washing, ventilation, etc. On the other hand, we have precariousness, especially financial one. Peru, for example, is one of the countries with the lowest public investment in health in the region, only 3.2. Only one country in the Americas exceeds the minimum of 6% stipulated by the WHO, Uruguay. The financial precariousness is expressed, obviously, in infrastructure and equipment deficits, as can be seen in the graphs prepared by the OECD and the IMF. The pandemic found Peru in extreme precariousness. A single public health laboratory with the capacity to produce only 500 molecular tests per day, when 50,000 were required, and with only 100 ICU beds when we required at least 5,000. The situation has been repeated in most countries in the region. Precariousness is also expressed in the shortage, as you can see, in most of the Latin American countries, the lack of capacities of the health system to respond to the pandemic is seen in these graphs. Hospital beds, ICU beds, ventilators. But also, precariousness is expressed by the shortage of qualified human resources, which are concentrated in large cities and mega hospital complexes rather than in the first level care facilities. Added to the precariousness is the fragmentation of the health subsistence and the segmentation of funds, which in the Peruvian case takes on terrifying dimensions. The historical, economical, political, and social and cultural evolution of the country has led us to have 33 health subsystems and more than 50 funds between public and private, which make management a very complex task. But not least, last but not least, corruption in the health sector. Already in 2019, the Comptroller General of the Republic determined that the health sector was the second most corrupt in the public sector and calculated that losses for that year are the equivalent of $300 million. Corruption is a phenomenon present throughout Latin America, and there is a generalized perception by citizens that the health sector is corrupt, affecting not only its financial sustainability, but also its reputation. The structural problems, there are other structural problems which I have not addressed due to time constraints. Weakening of public management, little investment in development and access to innovation in health, the permanent postponement of the first level of care, misinformation, among others. Now, I will move to the next stage of my presentation, focusing on some of the main challenges for Latin America. Being the first one, a rapid epidemiological transition. Now, every single country in Latin America has a different epidemiological profile than in the past. We are facing now huge demands from non-communicable diseases. The second is the rapid demographic transition. The third one is limited capacity to mobilize new resources to the system to finance universal coverage. The fourth one, explicit commercial, industrial, and technological policies are required to develop productive capacities, substitute imports, and generate technological innovation of a health industry of its own at the regional and national levels, because we have to address the issue of technological dependence. Poverty and inequality, which is South America and Latin America in general, is considered the most unequal zone of the world. And poverty continues to be in our agenda and undermines our efforts to extend health coverage. All these issues have been presented throughout our vast continent. However, they were concentrated or revealed in all their magnitude in the case of my country, leaving a very painful balance. I hope, colleagues, that this event will allow us to provide ourselves with new elements to be incorporated into the already complex health agenda of the region. All of the issues I have addressed, or the lessons we have learned from COVID-19 pandemic, are applicable to what we face now. We have to face the huge demands coming from non-communicable diseases: cancer, diabetes, hypertension, obesity, overweight, mental health, are waiting for the health system to focus their attention on them. It has been almost 2 years that we are in this battle against COVID-19, and it is time to extract the lessons, apply some measures, and address the new demands from our people. Thank you very much.
So thank you very much, Victor, for very nicely covering the overall situation in, the Latin American countries. And you have rightly mentioned that it has been a global epicenter, and highest death rates have been observed in Peru and Brazil. There are many health system issues which many of our countries are facing all over the world, and also issues related to financial risk protection and the challenges of universal health coverage. You have also mentioned about the socio-economic inequities which are present, and also one of the lowest investment in the health sector and fragmentation of the health system. Corruption is also one of the important issue, and the region is also facing epidemiological transition, and this transition is also contributing to the COVID pandemic, because most of the comorbidity and mortality in the COVID is due to non-communicable diseases. So most of the problems which you are sharing are also common for the Southeast Asian and many of the low and middle income countries. So I'm sure that this presentation has set a tone for overall situation, and we will take up the question at the end of the session. So once again, thank you very much. And moving to the next speaker is Dr. Bilma Arazola. She is the Director, Institute for Clinical Effectiveness and Health Policy, South American Center of Excellence for Cardiovascular Health, Argentina. She is a cardiologist and epidemiologist. Her research is focused on implementation sciences in the area of health system, health promotion, and management of chronic diseases. Dr. Irazola is the Deputy Director of the Master Degree Program in Clinical Effectiveness at the University of Buenos Aires. She is the Adjunct Professor at Cross Continental MPH College of Global Public Health, New York University, and Visiting Professor at the School of Public Health, Harvard University. And she also happened to be the coordinator of the World Density Federation for Argentina. So floor is open, Vilma, to you.
Thank you. Thank you. Thank you very much. Yes, thank you. I'd like to thank the organizers for your kind invitation and the audience for attending this seminar. So today I will share my screen now. Give me just a minute. So today I'd like to share with you some relevant data and some reflections on the COVID-19 pandemic and some of its effects on chronic NCDs in our region in Latin America. To start with, there are many factors that are connected with and that explain the big impact of COVID-19 on chronic conditions globally and also in our region, of course. Some of them are, or we can call them, COVID-19 specific factors. For example, the increased risk of patients with pre-existing chronic conditions who suffer from COVID, and the worse prognosis and all the consequences that we are very much familiar with. But it is not only about COVID-19 specific factors, we have also indirect health system factors. Dr. Zamora mentioned many of them, and I agree with him that these factors were already present before the pandemic, but of course are more visible and have a greater impact during the pandemic. And finally, we have other direct healthcare system factors that are very much related to COVID-19, and many of these factors we will talk about in a few minutes. I'd like to share with you this concept of the viral waves of COVID-19 and our pandemic, and the other waves that we have to deal with and that are related to COVID-19, but are not also, but there are not only COVID-19 and that affect the whole healthcare system. For example, when we talk about the viral wave, we are talking about the immediate morbidity and mortality of COVID-19. We started with the first wave, and then we have a second, a third, in some countries a fourth, and also a fifth wave of the viral pandemic. But then, as time goes by, we have other waves with other or connected or focused on other conditions and consequences of the COVID-19 pandemic. To start with, we have we can call a second wave of the impact of resource restriction on many other conditions because of of the COVID-19 pandemic. Then we have, or we can think of a third wave connected with the impact of interrupted care on chronic conditions. We will see some data about this. And also, I think that we are just now dealing with a fourth wave of problems related to psychic trauma, mental illness, economic injury, burnout of our healthcare professionals, and other consequences of the initial wave or waves of the pandemic. For example, in terms of NCD services that have been disrupted during the COVID-19 pandemic, we can see here these are data from WHO and it corresponds to year 2020. WHO, as you know, have conducted an extensive survey on the consequences of the pandemic on healthcare systems over the world. And the data that I will show you are restricted to our region, Latin America. We can see here, for example, some figures from 2020. In this graph, we see that many very relevant and important services have been disrupted partially or completely during 2020. For example, rehabilitation services, hypertension management, diabetes and diabetic complications management, and other chronic conditions. And this is 2020. As a summary, we have had a global decrease in services dedicated to chronic conditions during 2020 of about average 50–54%. In 2021, this level or degree of disruption is a bit lower, 37% average, so we are somewhat better this year compared to last year, but still we have a high level of difficulties in our healthcare systems. And what were the main reasons for this service disruption for NCD conditions, for chronic conditions in our countries? Again, in 2020, we can see here that most of the reasons were related to difficulties in delivery of care, outpatient care, inpatient care, healthcare personnel, resources. Many of these factors were very clearly depicted by Dr. Zamora in his presentation. Also, the lack or the shortage of medicines in our countries, in the region, were part of the problem. And this is 2020. In 2021, we still have the same problems. In this graph, we can see in the green bars the situation in 2020, and in the yellow bars the situation in 2021. So many of the problems have improved somewhat in 2021, but we can see here that we still have a high degree of difficulties, and also some of them are worse. For example, the insufficient staff availability, the human resources are scarce in the region, and also financial difficulties that started during the outbreak and lockdown procedures, but are still worse along the time. In this graph, we can see the access to outpatient services for chronic conditions. Outpatient services have been limited during the pandemic, and the same happened with inpatient services for chronic conditions, in particular elective services. In terms of the staff, a high proportion of the staff have been reassigned to COVID-19 response from chronic conditions care, both partially or totally. So that's part of the problem as well. In terms of NCD activities that have been postponed due to COVID-19, it is also important to highlight that implementation of NCD surveys, for example, that are so important to count with reliable information to make decisions in our region, all of them have been stopped, postponed because of the pandemic. Public screening programs for NCDs as well have been postponed, and mass communication campaigns directed to patients with chronic diseases or directed to health promotion and chronic diseases prevention have been stopped as well. Here we can see some of the strategies that have been put in place to overcome these NCD service disruptions during 2020. They include triage of patients to identify priorities at the healthcare facilities, telemedicine and telehealth tools to improve care. In many countries, we have started with different strategies connected with telemedicine, but the degree of implementation is very low because of difficulties in access these kind of tools in our region. Also, innovative strategies to improve delivery of medication, redirection of patients with NCDs to alternative healthcare facilities, and also task shifting and role delegation to non-physician staff. These are some of the strategies that we have been putting in place to overcome the NCD service disruptions during 2020 with different degrees of implementations in each country and within each country in different districts as well. What happened or what is happening in 2021? We continue trying to improve the strategies I have just mentioned, and there are other strategies that we are trying to implement. For example, in many countries, we are starting to resume community communications about health promotion and care of chronic patients. Again, telemedicine and telehealth tools, we are trying to improve access to these tools, but with a low level of implementation, as we will see in the next slide as well. Catch-up campaigns for missed appointments. This is something in which many of our countries are working. Integration of several services into a single visit to improve the efficiency of chronic patient cares, and also expanding facility hours after the big restrictions last year and at the beginning of this year. Here we can see, for example, that telehealth technologies to support service delivery were highly implemented in high-income countries, the yellow bar, but very, very much less implemented in low and middle income countries in the region. What about the impact of NCDs by COVID-19? We have been seeing an increase in acute presentations and complications of NCDs in general and cardiovascular and cardiometabolic conditions in particular, such as acute heart failure and exacerbations, stroke, acute coronary syndromes, a higher delay in seeking care by patients and receiving treatment, increase in uncontrolled hypertension, diabetes, and other chronic conditions as well. So looking ahead, our next steps, and there are many strategies that are being that we are starting to implement in our countries, is how to help people living with chronic conditions to plan their health care, monitor and manage their condition, getting a better adherence to treatment, how to increase self-awareness and self-management, empowering patients. Again, we are working on telehealth strategies and trying to improve access to these innovative tools. And we are also trying to resume community interventions. I would like to highlight here the role of this initiative from PAHO, WHO, the Heart Initiative in the Americas. Many of our countries, 16 countries in Latin America and the Caribbean, are part of this initiative up to now. And this initiative is based on the chronic care model developed by WHO and PAHO, and is many of the strategies proposed by Hearts in the Americas may be really important in helping us fight the consequences of this COVID-19 pandemic. For example, how to improve healthy lifestyle, resume activities, health promotion and prevention activities in our region, evidence-based treatment protocols, how to improve access to medicines and technologies, risk-based assessment, team-based approach to care, and monitor with high quality data. All these are strategies that are part of the Heart Initiative that may help in our fight over the to the consequences of the COVID-19 pandemic. This is another example from Heart, a risk factors calculator, which is available free for its use for non-physician healthcare providers like community health workers, for example, of nurses, and the recently delivered guideline for pharmacological treatment of hypertension by WHO. All these are examples of strategies that we can put in practice to try to improve care of our patients, even in this difficult context. And finally, I'd like to highlight the importance and the role of implementation science in this, again, in these difficult times. We all know that there is what we know, what is already known, what is needed, but another thing is what we do in practice, what we can do in practice. So to improve the level of implementation of all these strategies, we need evaluation, we need better designs, we need the support of implementation research, which is focused on bridging this gap between a lot of strategies that may be available and their actual implementation in practice. So, well, these are the first reflections that I like to share with you. Thank you very much.
Thank you, Dr. Vilma, for such a brief presentation, for such detailed presentation for the current situation and the impact. I would hand over the session again to the moderator.
So thank you, Dr. Vilma, for very nicely covering the topic and of NCDs and its impact. You have rightly mentioned that there has been disruption of the NCD services and what are the possible reasons and what are the strategies to overcome, especially related to telemedicine services, the task shifting, and also you have mentioned about the HEARTS initiative in the America, what is being done, and very rightly mentioned that this implementation research is very, very important. And in fact, I'm very happy to share with you and mention in the beginning also that under World NCD Federation, we have initiated now a Center for Implementation Sciences and Research. And there is a call for proposals which we are issuing for Latin America as well. So we will be very happy to support some of the projects as well. So we will take the questions at the end. Now, once again, thank you very much.
Thank you.
Moving to the next speaker. So we have listed Dr. Patricia, but somehow because of some unforeseen engagement, she could not join. So I'm going to another speaker, Professor Rajiv Saran. Professor Rajiv Saran is Professor of Medicine and Epidemiology, Department of Internal Medicine at the University of Michigan, Ann Arbor. His major research theme and research publication focus on cardiorenal issues and key topics of clinical significance in hemodialysis, especially vascular access and dialysis adequacy. He is involved in chronic kidney disease surveillance in US, the population health management, pragmatic trials, prevention of chronic diseases by lifestyle modification, eliminating health inequities, and increasingly global health issues surrounding kidney diseases and NCD. He is an associate director of the University of Michigan Kidney Epidemiology and Cost Center. He is on the International Advisory Panel for the World NCD Federation and also the chair for Second World NCD Congress, so which is going to be organized very soon, early next year. So I think he will also be extending you all the invitation to attend. So floor is now open for Professor Rajiv sir.
Thank you very much, Professor Thakur. Pleasure to be here and honored to be invited to one of the seminars that you've been so ably organizing over the years. So let me share my screen. I think that's going to be my first bit of a challenge here. Hope share. Can you all see my screen now?
Yes, you can see.
Okay, let me put it on presentation mode. So my goal, as instructed by Professor Thakur, is to cover the COVID-19 pandemic, its impact on chronic kidney disease, which includes AKI, in my view, and predominantly focusing on North America, US in particular, lessons learned and challenges ahead. So my goal would be to provide a very brief overview of the COVID-19 pandemic in the US, following up by kidney disease as a major risk factor, and that also as a consequence of COVID-19, lessons learned, challenges ahead, and some future considerations. So we've been lucky, actually, very lucky in many ways, although COVID-19 has disrupted life like never before in the United States. When I say lucky, the main difference, I guess, is the resources in the US. And originally being from India, I know what it means to live in a low resource environment. But at least here, despite all the troubles because of resources, there is a lot to be said for health systems and surveillance programs and implementation programs, all waking up to the need of the hour despite all odds. And so things are getting a little bit better. So far, as of today, there are close to 45 million cases of COVID-19 in the United States and 722 deaths. This is the count provided this morning by the CDC. And one of the admirable things about the CDC is it's giving us a day-by-day, week-by-week surveillance of the COVID-19 pandemic across the United States. And looking at their COVID tracker and trends, you can hone in to your region of interest. This is just a map showing the entire United States COVID case counts per 100,000 population. And at least you know what's going on, and you can go backwards and forwards in time. And this cdc.gov website, the COVID data tracker, is a phenomenal website that has evolved very rapidly after initial hiccups and provides a good ongoing picture of what's going on in the country other than listening to news. This is another picture from that website showing the daily number of COVID-19 cases reported to the CDC, highlighting the peaks and troughs that the pandemic has seen so far, starting from January 2020 on the left here up until October. So very recent data, so very timely surveillance. And I think the WHO on the international stage, CDC in the US, and several other organizations in the US that I'm aware of, the Johns Hopkins Surveillance Tracker, as well as the Institute for Health Metrics and Evaluation, these have really come to the fore in delving into very timely surveillance of this pandemic. So a big advantage when you know what's happening and where it's happening, the value of surveillance that I don't need to preach to this choir. The red line here displays the 7-day average, ongoing average of cases, number of cases, and each of the blue lines here, which coalesces into this graph, are the other cases, the actual cases of COVID-19 reported to the CDC. And again, it's a passive surveillance system. It relies on people sending in information, but it's because health systems are involved, they're receiving daily input, and some of it may not be absolutely accurate, but it's a great resource. So what about kidney disease in the US during the COVID-19 pandemic? I think a realization somewhere in the spring to summer of 2020 was that while kidney disease was not being mentioned previously as a risk factor, it very soon became apparent that a lot of people getting hospitalized with COVID-19 had kidney disease as a major comorbidity. And as you well know, and without going into details of epidemiology of kidney disease in the US and other places, kidney disease brings together a lot of other comorbidities. So while it's there, it's both a consequence and a cause for many other chronic diseases such as cardiovascular disease. Diabetes is, of course, underlying a lot of the problem, but more than half of kidney disease is not because of diabetes. And I know for a fact that in Central and South America, of course, kidney disease of unknown origin has been around for over 2 decades and is taking a huge toll in many countries there. This slide, I guess, I like to show this slide. This was published in a paper in Nature in 2020, and then highlighted in this review by Ortiz from the European Nephrology Conference organizers, ERA, the European Renal Association, and published in 2021. And this was a call to action by the Europeans saying that, hey, you know what, kidney disease is a major problem in relation to COVID-19. And it's a major risk factor for harmful consequences of COVID-19 as well. And in this slide in particular, which is a summary of the paper published from Nature based on a British surveillance program in the UK, about 40% of all health systems data was coalesced to calculate hazard ratios for COVID-19 mortality. And as you can see on this slide, people who are on dialysis, those with organ transplants, particularly kidney transplant, because that's the most common organ transplant, hematologic malignancies, other neurological diseases were also there. So they've included them in blue. But the purpose of this paper, this review, was to highlight the fact that all forms of kidney disease, particularly the more advanced forms, less so the stage 3, but stage 4 and 5, which is a glomerular filtration rate of less than 30, dialysis and organ transplants, but it is extremely high adjusted hazard ratios for COVID-19 related mortality. And this was a call to action that please recognize the fact that your patients, one of the major risk factors is kidney disease, and that it needs a lot of attention. People who have kidney disease are at extremely high risk. It's not just those with diabetes, chronic heart disease, and hypertension also highlighted here, but for comparison, the adjusted hazard ratios of mortality were extremely high in those with kidney disease. So having kidney disease is an extremely high risk factor for complications of illness from COVID-19. It's among the top comorbidities in hospitalized patients, unrecognized very often because of low awareness. There's a high incidence of acute kidney injury. And when acute kidney injury occurs, it typically happens not de novo, but in those who already have pre-existing chronic kidney disease and may have been mild, not recognized before that. But a very high basic risk factor is underlying chronic kidney disease. And there is a high incidence of acute kidney injury requiring dialysis and mortality, and especially high mortality amongst those with kidney transplant because they are immunocompromised, presumably. And several predictors of developing acute kidney injury include older age, which is of course a major risk factor for everything. Black race was identified in some of the papers that I've listed down here. Diabetes, hypertension, cardiovascular disease were other major NCD risk factors. If one was started on mechanical ventilation, the timing of start of mechanical ventilation in the ICU was often also related to the onset of or the recognition of acute kidney injury, almost within 24 hours of the intubation event. These people were also recognized as having AKI. So in the setting of multi-organ failure, of course, acute kidney injury was a very common occurrence requiring dialysis. And another risk factor for developing AKI, of course, was use of vasopressor medications. So it may have been a cause or consequence of the infection or the way the septic syndrome from the viremia is treated in the ICU. So this was about predisposition. This was about kidney disease being a risk factor for COVID-19. kidney disease is also a consequence of COVID-19. As already I've mentioned, it causes acute kidney injury as one of its major problems, and acute kidney injury has classically been related to chronic kidney disease. So that's one clear pathway of this syndrome. So here's a picture from one of the New York hospitals ICU, and these were scenes quite devastating scenes where overstaffed, overworked employees were battling this acute illnesses in the ICU, and dialysis machines were ubiquitous in this setting. This picture appeared in the New York Times, and the picture on the right was shared by a senior colleague in nephrology with me. So this is just a coalescence, just to give you a picture of what was happening. One thing, of course, is that the ICUs in big cities, in urban areas, were well equipped, but they exceeded the capacity, and a big ship had to be brought in to support New York in the initial phases of the US COVID-19 pandemic. So there was a lot of stress and mayhem around that time. A nice review by Brookfield, published in Nature Reviews of Nephrology in 2021, earlier in 2021, that highlights the various pathways, and I'm not going to go into that in the interest of time, but here's showing that dialysis patients are very vulnerable, and so are transplant patients to the virus. There's a very high rate of seroprevalence of infection among patients of dialysis, and also very high mortality risk. The kidney injury occurs through a variety of pathways that involve sepsis, inflammation, pneumonia, endothelial damage, hypercoagulability, cardiac dysfunction, drug nephrotoxicity. So multifactorial etiology of acute kidney injury. But it's postulated that it may be either direct viral injury, because the ACE2 receptors are present in high concentrations and they are upregulated in the kidneys, much like the lungs. So the lungs and the kidneys are prime targets for COVID-19 right off the bat, and lung, of course, being the first one. But once the viremia occurs, I think the kidney is the next most susceptible organ in the body, and the endothelial cells, of course, are a major target. The risk of AKI is very high. 30 to 50% of patients admitted to hospitals developed AKI, and once you have AKI or the acute kidney injury, mortality risk was emphasized in this particular review. One of the early papers that came out from the New York group of hospitals, a group of 13 hospitals in New York, that looked at their data retrospectively, looking at everyone that was admitted with COVID-19. They had over 5,000 patients. The median age was 64. And this was just over a month of data collection at the time, looked at retrospectively, a lot of acute kidney injury. So 37% in this series, all stages of kidney disease, of acute kidney disease. Stage 3, which is the most severe form of acute kidney injury, may or may not require dialysis. And this little graphic here shows you the timing of intubation, and the acute diagnosis of AKI related to that was very, very, very almost coincidental with the timing of intubation. So respiratory failure and kidney failure were almost simultaneous events. The risk factors for acute kidney injury were highlighted in this paper, as I've mentioned before, and very high mortality rate. So about 35% dead, only 26% discharged, while the remaining still in the hospital at the time of this data analysis. So the conclusion of this paper was that AKI, or acute kidney injury, occurs frequently among patients with COVID-19. It occurs early and in temporal association with respiratory failure, and is associated with very poor prognosis. There have been since this time other papers looking at the same problem. I'm currently involved in a multi-center analysis of COVID-19 and its impact on acute kidney injury from over 40 hospitals in the United States. And similar data is coming out. I cannot share that data because it's still being analyzed in its pre-publication. This is again from the same paper, I think, highlighting the fact that as these are patients with no acute kidney injury in the first bar shown here, and then increasing severity of acute kidney injury, death rates going up, discharges becoming less, and admissions, of course, are shown up here. So very high death rates is the main message of this. Here's another recent analysis of COVID-19 occurring in end-stage kidney disease in patients with different types of kidney replacement therapies, in-center hemodialysis shown in pink bars from different countries, including the United States here. This is data from the DOP study based on a survey of many, many dialysis units around the world, home dialysis patients, and kidney transplants. So this is the first phase. The top bar graph shows you data from the first phase, January to August of 2020, and then September 2020 to January 2021. So still now already old data, showing very clearly that in most countries, in-center hemodialysis patients had the highest proportion being affected by COVID-19, although the variation across countries is seen very clearly here, followed by home dialysis patients who were much less affected. Not surprisingly, these patients tend to be healthier and are isolated to their homes, so they have lower rates of exposure. And then transplant patients, surprisingly, were the lowest of the three, despite their immunosuppression. But again, transplanted patients are in general healthier and are on anti-inflammatory drugs in the form of immunosuppression. So whether that provides some protection or not is unclear. But a nice survey, a global survey that showed comparisons with between countries in the DOP study. I think they have over 13 countries. This is a very recent publication. Yet another paper published just 2 weeks ago in JAMA Network Open, showing the fact that as a consequence of COVID-19, in the blue line here, you can see that there was a dip in new patients. This was an effect on the health system, and uptake of new onset of chronic hemodialysis was lower in the months of March, April, May, and then picked up after that. So very quickly, it came back to the levels in 2020 itself, towards the later part of 2020 or middle of 2020. But there was a bit of a setback when all the dialysis services were not taking new patients, and it was hard, and patients may not have been presenting to the hospitals or ERs at the time. Again, showing the same on the right side as well. And this is all patients on the left side, and here it is highest quintiles of neighborhood social disadvantage. So the highest quintile was in blue, so it was mainly patients of lower socioeconomic status that were not being started on hemodialysis. So they were dealing with other problems and were not presenting to the hospitals and not getting started. So clear sign of disparity in the United States. And as you know, there are many, many disparities along racial, ethnic, and poverty lines in the States. This is, so this was a very, very quick overview. And now I'm going to move on to some lessons learned and then challenges ahead, focusing on disparities, social determinants of health, some things that have been termed political determinants of health, and then bring to your attention some of the rapid innovations that have helped us deal with the pandemic effects on this country. So this slide again is from the CDC site, showing tracking the pandemic weekly cases per 100,000 population by race and ethnicity. And as you can see, the blue line, the same again, showing the same peaks, but the blue line represents Hispanic patients. So these are from Central and South American country, immigrants and those living in the United States for very long, but they are among the most susceptible to COVID-19. The yellow line represents American Indian, American Native Hawaiian population. So that's another very highly susceptible population. Again, here, the third one is actually the African American population shown here in the light pink. I believe the white non-Hispanic population is shown much lower down, and the blue is the Asians. So the Asian and Pacific Islander and Native Hawaiian are at the lowest risk here. So a lot of disparities in who is susceptible to the disease by race and ethnicity, and this is the death rates again are among the highest in the death rates are different here. The highest one being in Native American Indians and Alaskan Natives, followed by Hispanic, and then African American, almost the same. But again, these are based on new cases and then mortality rates, just showing differences by race and ethnicity in the country. Again, these data are being analyzed more and more, and what is determining these differences is a good question. And I think it's mostly surrounds the social determinants of health, where people live, what sorts of access to healthcare they have, what sort of access to food and other facilities they have. A lot of the political climate, as you know, in the US has been volatile to say the least since 2016. And there are huge number of why the US was so badly affected, I think, is there are many questions surrounding that. Decisions taken at the highest levels are sometimes determine the outcomes that the country faces. And then, of course, the population and health systems reaction to that. There were many COVID-19 restrictions that were incrementally implemented across the United States, including state issued, again, health being a state level issue, state issued mask mandates, restriction of international travel, cancellation of major sports, educational, and entertainment events, closure of K through 12 schools, asking people to avoid gathering in groups of more than 10, limiting restaurants to only carry out services or no services at all. There was lots of closures and business failures, and requiring most businesses other than grocery stores and pharmacies to literally close down for varying periods of time. This happened in the early months of the pandemic, the first and the second wave. Here's a slide that shows that these things work. So this is one study uh, and shows that implementation of, in this case, I think it was masking, reduced the rates of infection subsequently. And here is when that mandate was taken out. Again, the rates of infections and death rates shown growing following that. So these things are very important, but implementation is what is difficult, and resistance of the population and problems due to misinformation compounds this. So this was reported in the MMRW, the Morbidity and Mortality Weekly Report, quite recently, showing the effects that masks do work in preventing infection as well as deaths on the right side here. I think one of the major positive things that were seen in during this time in the United States certainly was rapid innovations in many different areas. Telehealth was certainly implementation of an uptake of telehealth was a major one. This slide is from the FDA, the Food and Drug Development Agency, showing that there was a huge variety of testing and point of care and different types of tests being made available for COVID-19. This slide is, of course, very current as of September 2021 that I lifted from their website. They have authorized, the FDA has authorized over 400 tests and collection kits, and with different techniques. So a lot of access to testing is now available to certainly people residing in the US. The other big innovation, of course, as you all know, is developing COVID-19 vaccines at pandemic speed. And this slide is taken, a summary slide is taken from this New England Journal publication in 2020. It was an editorial that highlighted the difference between the traditional paradigm of vaccine development versus the new pandemic paradigm, which puts a lot of strain but utilizes past experiences and newer technologies that can, once identified the target, the antigen against which antibodies or vaccines need to be developed, and the decision to investigate those, the clinical development has been shortened compared to the traditional model of phase 1, phase 2, phase 3 clinical trials, rapid implementation of very expensive, high risk, high yield kind of vaccine development. I'm no expert, so I'm not going to go into detail of this, but this has been an amazing feat, I think, by the technological and pharmaceutical companies. And then a lot of people have doubts about its validity and its purity. And but I think in general, based on the experience so far, this has been a tremendous advance. So the vaccine is now implemented across the US. I think they didn't have data from Idaho, this one state, but all the other states, on average, the US population in general is 77% over the age of 12 has at least had one shot. Despite all the hurdles, this is again, I think, a major achievement. In many states, of course, vaccine uptake is much lower than others. Predominantly, I think it's in the South, but also in the Midwest and some northern states, very low uptake. And some of the states in dark blue here are the highest uptakers of. In Michigan, now it's about 70%. In Ann Arbor, the city I live in, it's over 80% first timers. So the future, I think, for COVID-19 and kidney health, but also what to watch out in general, is much higher adoption of telemedicine, which is, I think, here to stay. There's going to be potential increases in uptake of home dialysis because that provides, I think, a safer environment, the realization that home dialysis is good for you and can be organized if resources can be brought to bear. We're looking to accelerate the rates of kidney transplantation in the country. There was an executive order by the last administration, July of 2019, that highlighted three things. One was prevention of kidney disease, increasing home dialysis, and increasing rates of kidney transplantation. I think that's been taken very seriously by the community, by the kidney community. There's going to be changes in the rates of acute kidney injury, I think, with the new therapies and vaccines, more alertness to kidney disease being as a risk factor by health systems is already, the awareness levels the pandemic has raised the awareness, I think, for acute kidney injury as a complication. Long-term kidney outcomes hopefully will improve based on all of this. But the psychosocial impacts of COVID-19 on patients with kidney disease is yet to be considered and evaluated in an ongoing manner. I really like the slide which the previous speaker showed about the various phases of the COVID-19 pandemic. One of the biggest risks, I think, is the deluge of misinformation, manipulated information on social media that's ravaging most countries now and should be recognized as a global public health threat. This is a direct quote from Dr. Heidi Larson, professor of anthropology at the London School of Tropical Medicine and Hygiene, who wrote this editorial, this opinion piece in Nature in 2018, that viral misinformation compounds the problem. And she actually predicted that if this is not checked, and if another epidemic like the 1918 pandemic hits the world, it's going to be big trouble. and right, two years later, it is what actually happened. With that, I will close and acknowledge two individuals who really helped me preparation of this talk. Dr. Yun Han, who's an assistant research scientist on my team in the Division of Nephrology, Health Services researcher, and Emily Capillari, informationist at the Taubman Health Sciences Library at the University of Michigan in Ann Arbor. So I'm very grateful to these two individuals for rapidly compiling, because I had fairly short notice in preparing this particular talk, and But thank you for the opportunity, and I'll be happy to take questions.
So thank you very much, Professor Rajiv Saran, for giving us the overview of the COVID-19 pandemic in US, then COVID-19 pandemic and the chronic kidney diseases, and also highlighting the chronic kidney disease of unknown origin. You have very rightly mentioned that lung and kidney are the main target organs for this disease, and the risk of acute kidney injury is very high, especially during this pandemic. In a country like US, you have mentioned about this racial, ethnic, and socio-economic disparities, which has been seen all over the world, and especially in low and middle income countries. And you also mentioned that masks do work, and I think that is a very great message and which we should all follow. And also the rapid innovations which has taken during this time. Also this home dialysis has also come up in a big way. And you have also talked about this infodemics. People say this infodemics, that is misinformation and manipulation of information. This has been, in fact, a big problem in some of the states, Indian states, and especially in the Punjab, where I got the opportunity to visit as a central team leader. And there were a lot of rumors that, in the guise of giving, say, taking blood samples, they may harvest your organs, and even people were not allowing entry of the healthcare workers into the villages. So this type of misinformation is quite rampant, and in the state of Punjab, we even requested the state to set up these rumor registries at the district level, so that all these rumors are investigated and they are taken care of. So we have very nice presentation from all the three speakers, and now coming to the questions. And I'll pose few questions, maybe first to Victor. World over, it has been seen that there is a big problem in terms of employment, and also the humanitarian crisis which we have seen, particularly in many countries of Asia, where there were large-scale migration of the people during this time, and especially in India also. So what is your comment on this issue in terms of the loss of job, especially on employment front and the humanitarian crisis in the region? Victor, please unmute yourself.
My apologies. No, I was mentioning that in the case of Latin America, we are in most of the countries, if not all of our countries, have high levels of informal work, informal employment. In the case of Peru, it's almost 70%. The other aspect of employment is that most of our employees develop manual skills, are manual workers. So these two elements have worked against us in terms of controlling the pandemic. First, because if you have your incomes on daily basis, like washing cars or gardeners or any other type of work that you earn on daily basis, it is almost impossible to maintain the people locked.
Right.
One. The second is that most of them have no possibilities of doing remote work because the kind of work they do is manual. So they have to mobilize themselves to the place where they work. So the third element is in order to maintain them locked, I would say, the state has to put in place various mechanisms, like money transfers, for example, or reducing the price of internet connections, or providing food stamps, or even eventually providing them with food, baskets of food. All of them have worked differently in different countries, depending on the logistical capacities, depending on the financial inclusion. For example, I have been in India a couple of years. I was amazed of the penetration of financial inclusion. Everything is done by phone. In the case of Peru, for example, only 20% of the people living in Peru has a bank account. So the cash transfers were impossible to be implemented by internet or by technological platforms. It has to be in cash. People mobilize to the banks to have their monies. So everything worked against us in terms of having the public infrastructure to put in place the measures that we knew what we had to do, but we didn't have the infrastructure to put those measures in place for all. We were able to implement them for the most the richest. I mean, those who had the capacities to work at home, to have a internet, to have a computer, to have a bank account and smartphones, everything in place. It's a facilitating environment for maintaining me away from the virus. This was not the case for the majority of the Latin American people because of their living conditions. And I wanted to add something that I saw in the chat in terms of how quick we were in terms of implementing e-health or telehealth. And most of the Latin American countries were responded very rapidly on approving new legislations, norms, regulations, to rapidly have more access to telehealth. It was the case of Peru. It was the case of all of our countries rapidly approved various pieces of legislation, and we moved forward. And we made a huge jump in terms of using telehealth now. But again, telehealth reached the ones who had the tools. You know, in the case of Peru, primary healthcare, we have 8,000 health facilities. 70% of them have no access to internet, for example. You know, even for the health system, it was difficult to implement telehealth because of the lack of structural capacities to implement new mechanisms. And it was the same for the people. The second major barrier was knowledge. I mean, yes, now we have the tool, and we need to develop the skills to use electronic records and consultation, whatever, and eventually recipes. And thirdly, and codes and passwords and everything need to be put in place very rapidly. And thirdly, cultural. You know, it was not the doctors not knowing how to. It was not the health facilities or the doctors not having the tools to implement it, but it was the people very reluctant to use these mechanisms because they didn't how can I say, they didn't qualify this as a proper healthcare through a computer. But this is something that, as you know, is always change takes time. But eventually Latin America moved fast in terms of telehealth. But lots of things need to be done in terms of structural changes. I mean, these measures are not properly done by the Ministry of Health, but it's Ministry of Communication, Ministry of Transport, the other players in this area that need to speed up as well.
So very nicely covered, and I think you have very rightly mentioned that this financial inclusion is very important. And in fact, during the last 5-6 years in India, this has been a major initiative to open the bank accounts of every citizen of the country. And we have done a lot of progress. And this came handy during this pandemic because the government could transfer the money directly to the bank account of the people. Practically, this public distribution system and the resources they were, done. And this financial inclusion, I would say, is one of the biggest initiative which the Indian government has taken up. And there are two initiatives which has been started now in India. One is Digital India, and another is the National Digital Health Mission. So now this internet connectivity is really increasing in the health facilities in the area, and this telehealth and telemedicine network has, really come up, and I think this is required now, and you have mentioned about the progress. Now, Dr. Bilma, you are also a practicing cardiologist. So what are the changes you have seen in the routine practice of the people? And we have seen that, non-COVID patient had really suffered during this time, right? So what has been the status in Argentina and the other countries of the region?
Thank you, JS. Definitely. We have already had a gap, between the demand of services from chronic patients, cardiovascular patients, for example, or people with cardiometabolic conditions, and the services that we are able to provide to them, in particular in vulnerable populations. I took some notes here, listening to Dr. Rashid and Dr. Victor, and there are a lot of similarities, in our countries, even with the States, because you talked, Rashid, about disparities, because when we think of the US, well, it's a high-income country, we all know that, but there is high disparities in there as well, as it happened in our countries. So there are a lot of similarities, and I think, JS, that we can learn from each other, really. Also, about the solutions or potential solutions that we can implement. In terms of chronic patients in Argentina and in other countries as well, the big problem that we had over the last time is, I think it was at first it was about fear of patients to go to the clinics, to visit the doctor. That was a big problem at the beginning of the pandemic. So there was this great delay to get treatment, this great delay from the start of symptoms to receiving care. And that was in a high proportion because of the patient side of the equation. But then we have the other side of the equation, what is, of course, the services that we can provide. And we had many facilities closed or devoted to COVID, only COVID. So that was really difficult, especially for vulnerable populations, because they are used to go to the healthcare center that is close to their homes. when we had this redistribution of healthcare facilities, which were, which were allocated to attend COVID or not COVID conditions, many people was really not able to commute, and go to places that were far from their homes. So it was the both sides of the equation, really. And now we're trying to catch up with the situation. And we are, as Rajiv and Victor said, putting in place different strategies. But still we have structural problems to reach people, not to reach people. I agree with Victor that we have a lot of strategies that are approved in our country, for example, and other countries in Latin America. But from approving something to implementing, there is a long way, really. And we are we are far from achieving, really, those people who most need care. So that's the summary, JS, of the situation.
Yes, you are very rightly said that, this pandemic has highlighted the weaknesses of our health system.
Yeah.
And we really need to invest in this area so that, a strengthened health system can take care of many problems. So, Dr. Rajiv, there are a couple of questions for you in the chat box. Does the COVID-19 vaccine efficacy differ for people with CKD who are on immunosuppressant drugs? And there is also another question, is there any difference observed on the impact of COVID on CKD management in developing and developed countries?
Yeah, yes, thank you. Thank you for pointing that out. I was looking at those earlier. The second question first, I think that the comparisons between outcomes in CKD patients when they get COVID-19, I guess the question mainly is asking about AKI and its management and its sequelae. I think unless an international comparison study is conducted, I believe some efforts are going on in the form of surveys at different places in different countries. But as yet, I have not seen any major publication showing, there will be differences in outcomes, but whether that's because of management, access, ICUs, availability, care, the causal links will be hard to ascertain. I think it'll be descriptive. It'll be descriptive analysis as the DOPS survey has shown. You can do a survey and you can show differences, but the underlying reasons for those differences then may not be so clear. So that's the second question. I think I tried to answer it. The biggest confounder, of course, will be who's reaching those services. If most people who develop COVID, or 90% are dying before reaching the hospital, then you're only looking at a selected sample of people that arrive at the hospital and are able to get to the ICU. So a lot of confounders will exist, which will be unaccounted for in many of these analyses. I think it'll be a very tough comparison for AKI. For people receiving chronic dialysis or on transplant, it might be an easier cell, so might be easier to analyze. But for acute kidney injury, ICU services, there's so many variables that other than being descriptive, I think it will be a hard comparison. The other question pertains to vaccine efficacy among those who are immunocompromised, and I think that's a great question. Having said that, people are not doing antibody titers, at least in the US. That's not being recommended. There was some initial thought that they should receive the vaccination, and even if their antibody titers are below par, it's not necessarily that they're less protected. There's no direct correlation between antibody titers and the level of protection they see, because there may be other mechanisms that are not measurable in the form of antibody titers. So vaccination, and in fact, mortality rates among transplant and dialysis patients have been surprisingly low uh, compared with what was originally expected.
Right.
It looks like the energy that exists among dialysis patients or the low immunocompromised state in end-stage kidney disease patients in general somehow reduces the inflammatory consequences of COVID-19. And that's purely speculative. In transplants also, they are on a lot of immunosuppression. So on the one hand, they are susceptible, but on the other, they don't mount that inflammation. So if the virus doesn't mount inflammation, it's not as harmful. It can still kill by direct toxicity, but if the inflammatory component is not as big. Again, I'm speculating heavily here, but we've not seen masses, and these patients are taking precautions to begin with. A transplant patient typically wears a mask when they come to clinic, or especially in the earlier stages, or when they are profoundly immunocompromised. So we have not seen, but yes, there may be differences in efficacy. We are recommending full booster doses for all transplant individuals, but no more than 3. I mean, people are not saying that you keep on getting boosters. Maybe
Right.
there will be annual vaccinations in the future, but so far
Yes,
that's,
so I think you have also highlighted this data availability issues,
yeah.
which is a in fact a big problem in all the low and middle income countries, because if we have to analyze this data of this comorbidity, maybe due to COVID and say CKD, you may not find data in many of our countries available, right? So that is also an issue. And this, the difference in mortality in different countries, I'm sure that aspect may be taken up by the global burden of disease, because they publish the data
Yes.
country wise at some stage, and there is some work which is going on. The another important issue, maybe I can pose this question to Victor. This vaccine, distribution, coverage, and equity issues in vaccination is very, very important in many of countries, particularly in Southeast Asia and many. So what is your comment on the vaccine availability, the coverage, and also especially the equity issues in South American countries?
Well, there are two elements here. Some of the countries are doing very, very well, like Chile, for example. Chile, Brazil also has gained a lot of speed. We have, in Peru, have reached 50% of our population vaccinated, completely vaccinated yesterday. And even we didn't stop, even we had elections and we have a new government coming. The process has not stopped. So the acceptance of the vaccines is very high. Anti-vaxxers have not played a major role. The major difficulties were related to 2 elements. The first one is access to market of the vaccines, either because we didn't have the knowledge and the capacities to move rapidly in that market, in that wild market. And secondly, well, related to that is because we didn't, as in many other areas, and this is something that I have not mentioned, but I will mention now, that we in Latin America and in some other regions in the world, we have a supranational structure, mechanisms that were put in place long before the pandemic, but didn't work for this pandemic. Exchanging knowledge, capacities, holding hands together to being able to access, for example, to vaccines, as in the past to PPEs or ventilators or molecular tests. I mean, we were not able to use the mechanisms that were in place to be used, either because these mechanisms were not prepared for this pandemic as well. But on the other hand, because our countries as well, we were facing various political turmoils that didn't allow to the same minister attending to the same meetings all the time. You know, constant changing was a bit of a problem. That's the reason why in our region, COVAX is not a major player. I mean, every single country had to mobilize their own resources, their own knowledge, their own capacities to access this wild market. And on the other hand, in terms of reaching out our population, the same problems. Most of urban areas were covered very rapidly because those are the places where most facilities are located. But the further you go, the upper you go, is more difficult for the vaccines to reach the people who are in most need. We have some problems organizing our vaccines campaign at the beginning also, because the system in general in Latin America is so fragmented that every single subsystem put in place their own vaccination strategy. Social Security for Social Security people, Minister of Health for its people, and police forces and the health system for police forces, and so forth and so on. That was a mess at the beginning, a mess. So I know from other experiences in Latin America, they face the same thing. Those countries with that had the capacities of strong governance capacities to put in place one campaign for everybody, all the citizens treated as equal, were more successful. The second organizational problem was for those countries that were waiting for the people to come to the vaccination centers, instead of the contrary, vaccines reaching out the people on their jobs, on the markets, on the streets, or at different times, because 70% of the people are manual and informal employees. So for them is to choose, either I go to the health center to get my vaccines or I work. So this is a difficult choice for them. For this reason, the ministries of health had to mobilize huge amount of people, and this is very costly in terms of mobilizing resources, to different areas to reach out. So in summary, yes, we are moving forward. We are better than most of the African, some of the Asian countries, but we are still behind the developed countries because the lack of access to market for various reasons, and due to problems of organization and fragmentation of our systems.
Right. So there is another related question, that what are the impact of long-term this COVID pandemic on the health system and NCD care in Latin America? And especially, I mean, related, in some of the countries, we have seen this political instability is quite common in some of the Latin American countries. So how it is going to, affect the health system?
Well, if you're asking me, well, since I am taking the floor now, well, in terms of political instability, it's something that we are going to live with I think for a long period, because we are every single country in Latin America is having this polarization process, and not only Latin America, but also in some European countries and eventually in the United States, as we have seen. It's very polarized. Using masks is a polarizing issue. Vaccines is a polarizing issue, and lockdowns is a polarizing issue. Everything has become very political in this pandemic, and this is something that is going to affect the implementation of the health system. But there is another drawback. There is one aspect of vaccines. Vaccines has come as a savior for most of us. It is indeed something marvelous that we have developed. We have, as the humanity has been able to develop this vaccine in such a short period of time. But for those who work in health systems, the vaccines is working against us, because now that the vaccines has come, now everybody's moving to a different issue. Pandemic is not more a complex, it's not about health systems, it's about vaccines. The agenda has been reduced to one topic. Either you get the vaccines or not. What about financing? What about organization? Yes, let's move forward. Economy. The economy is first now. We have to recover the economy. We are losing ground in terms of putting our agenda, in terms of reforming the health system, improving the health systems, because we have a vaccine. Paradoxically, vaccines, which is a marvelous thing, is playing against the health system agenda in every single country. The health system agenda is fading away, I would say. Sorry about the extent of that.
Thank you. Maybe to Dr. Bilma, so although it has partially been answered, what is the status of telemedicine services in Argentina and the South American countries as such?
Sorry, JS, I have this level of poor connection and I missed part of the question.
Okay. So, I mean, I can again repeat, what is the status of telemedicine services in Argentina and also broadly in other South American countries?
Thank you. Well, I can tell you what is going on in the region in terms of telemedicine and telehealth tools, because there are a lot of tools available now, or more and more available over time, related to information systems in general. For example, the role of information system for clinical appointments, for reminders of clinical appointments, different strategies, remote strategies to manage the delivery of medication. So all of these tools are under the same umbrella of telemedicine, telehealth tools. And we are in general, of course it's different from country to country, but in general, as Victor said, I think, we are improving a lot from a technical or technological point of view. The problem, again, is implementation, adoption by healthcare providers. Many of them are not prepared or not well trained to use these tools, or they don't trust these tools, you know, and they keep using a paper-based form, for example, and things like that. And on the other hand, access from the population is a major barrier as well, because mainly of connectivity issues in many of our countries. And behind all this, there is, and I took it from you, Rajiv, the political determinants of health, because we all know about the social determinants of health and the policy measures and everything, but the political determinants of health, I'll take it, Rajiv, from now on, because I think those are powerful determinants, really, and there is business, you know, behind all these tools as well, and that is a major problem as well in our countries. But having said that, we are making progress, no doubt about that. Right. I think it's the future, really.
Yeah. So maybe one question to Dr. Rajiv. Rajiv, we have seen that we are working in our specific area of work, right? But this pandemic has taught us that not only non-communicable diseases are important, but at the same time, communicable diseases are still a big problem, right? And this integration of medicine is a very important issue. We cannot escape in not working in communicable diseases as well. So how do you see that the future of this integrated medicine in the times to come, keeping in view of this pandemic?
It's a big question, Thakur. You and I should write an editorial or something. But on a more serious note, I think this is huge. I think the era of infectious disease being the dominant problem, we assumed that we had the luxury, at least for some time, thinking that, oh, it's chronic disease now. We should all focus our attention on non-communicable diseases. But we forget the fundamentals that if we don't keep check on infectious diseases and don't take the fundamental precautions of hygiene and pandemic prevention, the constant vigilance is needed. But I think the biggest lesson for me is cooperation between the public health enterprise and health systems. In the US, for the most part, they don't hobnob with each other. They are isolated. They are compartmentalized. The School of Public Health, for example, I mean, in Michigan is a very, very classic example. We have a School of Public Health, School of Medicine right next to it. There is collaboration at the academic level, but there's not collaboration in the improving the health of the population level. It's not symbiotic in that sense, and therefore not synergistic either. So those are my quick takeaways, and I think moving forward, I would like to see more interaction between public health information and health systems strengthening, and health systems taking a more open-ended, open-armed approach towards public health. Because right now, our health systems are constantly focused on dealing with crises, one crisis after another. They really need to mingle with the public health enterprise and cater to the health of their populations they serve, as opposed to just people who land at their doorstep.
In fact, one of your theme of the next World NCD Congress, that is learning health systems, makes a lot of sense now.
Yeah, I see surveillance as a learning system. And when I talk about surveillance and its principles, I say, hey, learning health system is the new word for surveillance. But the way the learning health systems are different, that they have energized surveillance, meaning they monitor and then they take action and they continue to monitor, they engage stakeholders more actively. So it's a more active form of surveillance in that sense. And chronic disease surveillance can learn lessons from the modern version, that is the learning health system concept. The two have to mingle. So it's a public health and health systems mingling. I think that's more important. We overcame the pandemics of the past, and the infectious disease era became past history simply because of the cooperation between public health and health systems. We've forgotten those old lessons, and I think we need to revive those.
So I think we are coming to the close of this session now, and from the dialogue which we have and the input from the audience, we have found that there are many challenges as far as health system is concerned. There are racial, ethnic, socio-economic disparities in Latin America and also in US, which is also common in other low and middle income countries. But this COVID pandemic has provided us an opportunity to strengthen and invest in our health systems. Vaccine distribution is a important issue, and I think it is picking up, although there are some disparities as far as non-communicable diseases are concerned, and same has been seen in the Latin American region also. And I think the medical practice has changed, and this telemedicine and teleconsultation, the digital health issues are very, very critical, to address the challenges which has been posed by this pandemic. On behalf of World Density Federation, I take this opportunity to all the three speakers who have really, covered the topic very nicely. Victor, Bilma, and Rajiv, thank you very much for sparing your time and be with us. And for those from Asian countries, because for us it is now the late evening and they are sitting here. So I thank you all for being with us and be present. And I think we have learned a lot from this region, and the problems are common, and collectively we have to address them. So with this, we close this session. Thank you very much.
Thank you very much.
Thanks for the opportunity, Thakur.
Thank you very much.
Thank you.
Great to meet you all.
All the best.
Thank you.
Take care.
Nice to meet you all.
Nice to meet you.